Okay, so we're gonna show another case. I'm gonna start our another interesting live case demonstration. I'm gonna introduce our team and Hyunwoo Park. I'm D.W. Park from Asan Medical Center. Hyunwoo Park she is my previous fellow now, a professor in the Suncheonyang University Hospital. Our senior fellow, Dr. Jo, and our senior assistant. We prepared all the case. And okay, Dr. Professor Park, can you present patient history?
87 years old female was admitted for aborting chest pain started from 2 months ago. Her coronary risk factors were diabetes and hyperlipidemia. Coronary angiogram shows severe stenosis at distal leg main and proximal sulcal ostium. Next. Syntax score is 14.
Okay, so this patient is 87-year-old female, and I'm gonna start my case presentation with the show. This is aerial coral view. I'm gonna ask a vote for the panel and the discussant. How do you think about the sulcal ostium? Definitely there is a distal leg main severe calcification disease. How do you think it's sulcal ostium?
Well, I mean, do you have another view before you
Okay,
before we
next.
do that?
This is a spiral view, and there is some hedginess of the distal leg main. Okay, another view. This is the areocranial view. Okay, let me show additional view to clarify. Okay, next one. This is the areocranial view. I show the full view.
Okay. So let's just, there's no question about the distal left main lesion. The issue has to do with the LAD proximal and the circumflex proximal. So any comments from the panel as to what they would do, what they think?
So I think, Professor Ba, can you hear
Yes.
me?
Okay, I can hear you.
Okay.
Yes.
So I think it's very heavily calcified in the left main in the circles. So I think it's just coronary angular finding. We cannot see some plaque burden or some calcification is superficial or deep calcium. So I think it's maybe it's the imaging analysis. I think it's most important thing for this situation.
Definitely. Yeah.
Okay.
So, definitely, as you mentioned, the Professor An, this is a case, I think, a typical case of the leg main. How do we do IBUS? The Professor Minch is a master of intravascular ultrasound, and I remember this case shows how much discrepancy angiographic finding and IBUS finding for leg main disease is some calcified region. This is, I think, a good representative case why we do IBUS.
So does anybody else on the panel have a different viewpoint?
I think this is from this view. It seems that the patient has a true left main bifurcation stenosis 111, and the lesion in the circ is very short. So maybe we can do just apply just one stent procedure, so stent crossover procedure, but again, we need to do IFUS. And then another option would be to do DCA if DCA is available, because the lesion is very eccentric. It's very ideal for DCA.
I mean, before I would do DCA, we have some Japanese on the panel that can comment, but an 80-some-year-old woman with some calcification of the coronary arteries, before you do DCA, you really should do imaging. You make sure that this isn't just
DCA plus stenting.
Well, you may not get anything with DCA. This is all calcium.
Yeah, of course.
So show us the images.
Okay, got it. Okay, we're gonna first show the IVUS from the LAD to distal leg main, and then we're gonna show again the SOC to leg main. This is the LAD to the leg main, and the vessel size is 3.0, is the mid part of the LAD. We can see some calcium. This is a septal branch coming. Okay, might be that point, just distal point is our landing zone, and here is the vessel size 3.5, and we can see the eccentric calcium not some circumferential calcium, you can treat well that region. Okay, this is a lumen was maintained. Okay, and this is a LAD nearly ostium, and then you're gonna see the suck. 조금 빨리 갈 수 있어, 스피드를. Okay, okay, okay. Suck ostium was coming. Okay, we can see what's happening. Suck ostium. Yeah, so because of that, you're gonna treat the
Okay.
lemon main. Definitely, we should the post branch. Okay.
Okay, so the ostium of the LAD is not bad, although there is diffuse disease. The distal left main lesion is a calcified nodule.
Yeah.
Okay.
Okay, show again the suck ostium. Okay, this is a suck view, and then here is the vessel size was okay. Start. The prox suck and the 3.5 vessel, and then we can see there's some calcium. So we can see morphology of the suck ostium. There's angiographic clear clarification is not easy. Okay, this is nearly the suck ostium. Okay, we can see over here and the very tight stenosis and the severe calcium. This is the distal main. We can see how much narrowed the distal part of calcium and suck ostium of calcium.
So two quick comments. Number one, the circ ostium is very focal and very calcified and very tight. You cannot assess the circ from the LAD pullback. You cannot assess the LAD from the circ pullback. You must image from both. And the distal left main lesion is a pure calcified nodule. So what are you going to do?
So,
Do you think it is necessary to do a root ablation, considering such kind of iris finding, not circumferential calcium?
yeah, right. Sometimes we consider rotablation, but initially, we further consider is a less invasive strategy is the non-compliant balloon, cutting balloon, and some scoring balloon. If failed, we consider rotablation.
The calcified nodules are an interesting phenomenon. You usually don't have to do that much plaque modification because there's a normal arc of vessel wall opposite them. You don't get a beautiful round stent, but you do get a good acute result. And if somebody who's in their late 80s, you may not want to get too complicated. This is not a case that necessarily would do well with DCA, by the way, if we had a standard DCA device, although it is possible to modify, this is going back 20 plus years, you can modify an atherocath to make it more likely to cut calcium, but requires a change in the engineering.
Very nice comment.
I completely agree that in the presence of a lot of calcium, DCA is not advisable. You already have two wires, one in the circ, one in the LAD.
Yeah, right.
If we want to proceed with rota, we can still maintain both wires, but by using guideliners.
Yes, so, okay, sometimes we do the left main rotablation, but not frequently, and usually the non-compliant or another option usually work. Sometimes if everything was failed, we do rotablation. So, okay,
Okay,
Go ahead.
Go.
okay, so in the next step, we select 2.5 non-compliant balloon, next one. And the first one, if you're gonna treat the very severe calcified left main region, I recommend a more strong support. This is the XB guiding support. I put the guide wire. This is a 2.5 NC balloon. We inflate up to 30 ATM. Next one, several times, 2, next one. And then we're gonna perform the LAD distal main dilation using 2.5 high pressure dilation. And the next one time again up to inflate the 30 ATM. Okay, this is the view of after just a non-compliant balloon dilation, we can see severe dissection. So at this point, we recheck the IVUS circle, what's happening after pre-dilation. So at this stage, we require additional low ablation or additional step. So I think that is another debatable portion. Can you show us the immediate after non-compliant balloon IVUS image? Yes, this is a PROXSUC. This is you can see the calcium. We already performed high pressure dilation. Over here, there is some laceration of the calcium of distal main. Okay, this is dissection of the lamp main. So at this stage, I'm gonna do stent advance. Some calcium was dissect. Usually, if calcium was dissect, then advance is usually feasible.
So what is what is your approach? What are you going to do?
Yes, I'm gonna do. Suck ostium was involved. Distal lamp main was involved. I'm gonna do crush technique, balloon crush technique.
Dr. Lee, would you consider cutting balloon at this stage to have a better preparation of the lesion?
안 들어가지? Oh, yes. You can see. Okay, additional balloon. 자, some if doesn't pass well, we require additional 3.5 inch 하나 줄까? 15mm.
How do you think about usage of a big cutting balloon?
Yeah, right. Okay, I'm gonna use additional non-compliant balloon. It doesn't work. I'm gonna do some cutting or scoring balloon. This is a 3.5 NC balloon. 3.5. You want? Okay.
If there is an eccentric calcium chunk like this, even though balloon inflation, there's no indentation, after deflation, calcium chunk recoil into the lumen. That may hinder the advance of the stent.
Yeah,
Because
yeah.
I'd like to just crush the calcium chunk into a smaller size.
Okay, if doesn't work, we have additional next option like a Hydrogilla and something like that. This is passed well 3.5, text 1. 자, go. 10, 12, 14, 16, 18, 20. Okay, deplete. Okay, go. 20. Okay, inflate well. Okay, deplete.
So we cannot see the indentation, full
Okay,
dilatation.
test.
Plus, the calcium is
좀
extremely
바로바로
eccentric,
하세요.
so
자,
you're just
Yeah.
you're displacing the normal vessel wall.
Yes, replace and recoil. That's it.
Okay, deplete.
The additional ballooning not meaning because
So,
already dissected here. If ballooning
당기면 안 돼.
there,
뒤에
just
조심해.
soft part is only the dilated.
가만히 있어.
So Professor Pa, I think it's even though you got some full expansion of
Yeah.
the balloon, I think it's maybe it's more some aggressive, some like calcium
Yeah.
modifying the procedure.
Using cutting
maybe it's
or scoring.
necessary, I think.
Yeah, yeah. Okay, I tried first. It failed. I'm gonna do. Okay. So this is Ultimaster 3.5. Okay, the guiding is push up. This is XV guiding caster. 와, 안 넘어간다. 잠깐만. 안 넘어가.
선생님 LED 앵커 하시고 하셔도 됩니다.
앵커?
지금 본론
아니야,
준비되어
이게
있습니다.
지금 들어갈 게 아니고 커팅 한번 해볼까? 3.5 있죠? 커팅 주세요. 이거 스탠을 다른 거 줘야 돼요. 뒤에가 휘었어. 오케이. I'm gonna do cutting balloon.
What kind of stent did you try?
This is Ultimaster. This is 3.5. New one으로 주세요, 스탠.
Just one question. Is there any concern of cutting balloon with another wire inside a calcified lesion that you may cut the wire?
Usually okay.
It's very, very rare, usually
Yeah.
impossible to cut the guide wire with cutting balloon.
잠깐만. 와, 이게 저 와이어가 킹킹이 됐나
But you
봐.
know, what I think is happening is
Okay,
that the
there is a
eccentric
wire-
calcium, that
와이어를
the
새로
wire
위에-
is
another 와이어 하나 더 줄까?
passing into the cracks of the eccentric
BMW.
calcium. And because the typical calcified nodule, it's not just like a smooth rock. It's got these, ridges and crevices to it, and
Yeah,
which
yeah.
you could see on imaging. So the wire is getting trapped, and whatever
Definitely.
you're trying to advance, if it's relatively bulky, runs into this.
Yeah,
And
right.
It's almost as if the wire is in a dissection plane, but it's really not a dissection plane. It's really a crevice in the calcified nodule.
자, 토크 introduce. Okay, as you commented by the Gary Means, that is exactly there is a some wire kinking of the proximal part. Is I'm gonna put the additional wire to the main branch.
So if we just move the wire to and fro, then we can just release the wire entrapped in calcium.
Yeah.
Yeah, it's possible. I mean, there are lots of theoretical tricks,
Okay, test.
but I don't think there's necessarily one that always works.
테스트. 자, 스파이럴 한번 가볼까? 스파이럴. 오케이, got it. 자, 보여주고. 오케이, 테스트. 오케이, great. 자, 이렇게 하고 잠깐만 내버려둬. 가만히 있어. 자, 우리가 NC 볼룬 하나 줘볼까? 앵커링 하나 한번 해볼게. 뉴원으로. 요게 LED죠? 요거는 서커고. 오케이, got it.
Thus, do you give up cutting balloon? Just
우리
just
아직
anchoring
커팅 안
and
했지?
advanced stand?
아까 커팅 나왔구나. 오케이, I'm gonna do 커팅. Okay, this is 3.5. Okay.
If you encounter difficulty in advancing your cutting balloon to the circ, another option would be to use body wire technique to the circ, or even body balloon technique to the circ.
가이드 확실히 밀어넣고.
The third option would be to use a guide liner or guide
자,
sealer.
이거 두 번째 이걸 빼버리자. 요거지? 요게 세 번째 들어간 거, 마지막 거. 트랩된 거. 자, 이거 뺄게. 잡아. 자, 잠깐만. LED. 여기 LED지? 오케이, 테스트. Okay, you can see how much. Okay, got it. 자, 여기서 노미널. 6, 8. Okay, save. Deflate. Nominal 6. Okay, go. 6A.
Is this cutting
Yeah.
balloon?
Yeah.
Yeah, this is 3.5. Deflate. Sometimes Antonio Colombo suggests a high pressure cutting balloon, but I have much experience with high pressure cutting balloon. I usually do 10 ATM, 12 ATM test. 자, go. 6, 8, 10, 12, 14. Okay, deplete. Okay, 자, go. 10, 12, 14. Okay, deplete. Okay, I think we can pass it. Okay, go. 6, 8. We drag cover whole region.
I think it
10,
is very
12.
important to repeat cutting
Okay,
ballooning.
deplete. 자, go. 10, 12, 14. Deplete. 자, one more. Go. 10, 12, 14. Okay, deplete. 오케이. And then 커링 볼론. 이제 3.5 하나 주고
스탠으로 드릴까요, 네?
그 NC 볼론 있죠? 어차피 저기 그 트래핑 해야 되니까 3.5 15.
3.5, 15 NC 볼록입니다.
안 들어가면 이걸로 했어. 자, 진통제 조금만 드리세요. 네. This is a 3.5 NC anchoring.
Could you check by eyebrows?
오케이, 엔지오 한번 찍어보자. 엔지오 ready. 풀샷. 오케이. 자, 들어갈게. 뒤에 바짝 잡고. 자, 들어갑니다. 진통제 조금 드리세요. This is 3.5 NC balloon for. 어머니 조금만 참으세요. 오케이. And then stand. 내려놓고.
스탠 드리겠습니다.
It looks better after cutting ballooning.
Yes, yes. 오케이, 자가. This is new one. 어머니 조금만 참으세요. 자, 오케이, got it. Much better. 오케이. 자, 요거 NC 좀 당길게. 자, 테스트. 오케이. 조금만 더 당길게. 천천히 하면 돼. 혈압 괜찮고. 자, 테스트. 오케이. 나쁘지 않다. 조금만 더 빼서. 자, 한번 다시. 한번 찍어볼게. 엔조. 풀샷. Yeah, I think it's good. Okay, go. Stop, go. 9, 10, 12, save. Deeply. Okay. Vital is okay. Just pull back. 자, go. 6, 8, 10, 12, 14. Okay, deeply. 여기 두 가지지? 자, 당길게요. Okay. Pull back the stand and wire. Okay. 이거 잡고 한 사람 잡고. 자, 천천히. 자, 테스트. 자, 고. 10, 12, 14, 20. This is 3.5. 24.
3.7.
Okay, deeply. Okay, we're gonna check it up. And you're ready?
네.
자, 풀샷. Okay, great. And then L8 is a 3.5, 20 얼마로 나왔죠 아까? 33. 우리 저기 풀 커버 메인까지 달려니까 그냥 38이 낫겠다.
메인까지 다 하시게.
오케이.
네, 좋습니다.
저 다이섹션 있고 그래서.
3.5 by 38.
Yeah, 38 for the, I'm gonna fully covered at the point of the septal branch, fully cover, and also as well as there is some severe dissection left main, I'm gonna try to fully cover that region. Okay.
But you have to consider size approximate to mid LAD.
This is 3.5 on the basis of IBUS and distal part 3.5, proximal part 4.2, 4.3, and we're gonna do additional high pressure balloon dilation. Okay, 뒤에서 천천히 보자.
So while you're doing that, let me ask the panel. The ostial circumflex was obviously severely diseased. The ostium and the LAD, not so bad.
Okay.
Would anybody have done a single stent crossover into the
거의
circumflex?
그 정도까지였나?
셉탈에 맞추시고.
오케이, 테스트.
테스트.
좀 더 빼야 되겠다.
네.
잠깐, 조금 더.
I'm
테스트.
afraid
No interest.
after stenting the
더
circumflex,
네.
I'm afraid the carina shift
네.
to the LAD. So some the stenosis
한번 찍어보시죠.
occurred by the carina shift to
나쁘지
the
않은 것
LAD.
같아.
So we should check the LAD by eyebrows.
그지? 딱 거긴데. 뒤에가. 자,
Actually,
고.
the
Six.
ostium of the circumflex has a
Six.
nodular
Eight.
calcification. Its cause
자, 기다려.
carrying a shift.
save.
So I'm afraid the
Flip.
stenosis of the osteal
3.5
LED
NC
by
뒤에서부터
stenting.
한번 해주죠.
But let's assume for a second you do a stent from the left main into the circumflex.
Okay.
The LED
Ready?
ostium is not compromised. It's not compressed or anything. You've got a good acute result. How many people are happy?
Yeah, but
I mean,
we should check by
we-
IVUS from LED.
No, I understand. The LED looks okay. All right? Assume the LED is okay. The question is, are people doing crossover from the left main into the circumflex, jailing the LED, assuming the LED has a good acute result? Because there's no data on it, but we talk about it. And this is not, in some ways, 86 years old, that's not necessarily a horrible thing to do. But are people, or are people afraid to jail the LED under any circumstance?
자,
네,
4, 6, 8, 10. Okay, save. Deplete.
If the LED size is not so big, I
자, go.
totally
10,
agree
12.
with you. Left main to circ single stenting
Okay, save.
would be
Deplete.
beneficial for the patients in the long-term
20.
wise. As, even though there is a
Okay,
mild
deplete.
degree of lesions in LAD proximal
Okay,
part,
20.
we can just treat the left main to circ
Yeah.
with single stent.
I mean, that was I'm kind of asking as a question, because I don't have a strong opinion,
Okay, got it.
but
짧은 거.
it seems,
네.
on one hand, attractive, on the other hand, unsettling, because we don't know really what's going to happen at the ostium and the circumflex long term. Because we know that when we stent across the circumflex, even if we get a good result, there's a certain percentage that come back with restenosis. But we don't have any data on what happens to the circumflex, so the LED in a, if we do the opposite.
In my impression, if we perform single stenting from left main to circ also the stenosis is nearly zero. But when we
잘
perform
되고 있어요.
two-stent technique to save just mild, moderate degree of stenosis in LAD, then actually circ osteal restenosis is very high.
I know, it's,
There's a single stenting from left main to circ is a really good option, depending on the
6, 8,
patients.
10. Okay, this is part. Okay, deplete. This is 4.5. Before the recrossing, we're gonna do part. The main size was on the basic side, so we guarantee 4.5. Oh, go 6 nominal.
12, 4.5.
Okay, deplete. Okay, 잠깐만.
네, 좋습니다.
조금 더 나야겠다. 어머니 조금만 참으세요. 자, 고. nominal 12. Okay, 14. 16. Okay, deplete. Okay. You're gonna check it up. 자, 갑니다. 자, 풀샷. Okay. There is some indentation over there. I'm gonna do again. 어머니 조금만 참으세요. 자, 테스트.
so
오케이, 가보자. 자, 고. 6, 8. 조금 롱 듀레이션. 10. 12.
So there are two potential reasons for that indentation. One is that the stent is not fully expanded. But the second is that you've got calcium prolapse through the stent struts. And at some point, you'll have to do an IVUS run to separate those two out.
Okay, deplete. Okay, and then the recross the wire, choice PT,
Dr. Mintz,
Yeah.
spider branch.
usually some
I can't hear you.
suggest to use a semi-compliance balloon for post-dilation for a lesion like this with a very eccentric lesion. maybe it may enhance some apposition at the so for those very asymmetrical lesions, do you think it makes sense based on intravascular imaging?
You will not get full apposition and the transition from the calcium to non-calcium, especially if it's a calcified nodule. There's no way to do that. It's just that the metal will not take that conformational change. What we don't know here is exactly why the distal left main looks a little funny. Quite frankly, the lumen area could be large enough that it will be totally okay, and you don't have to chase it at all.
So you don't think a semi-compliance balloon could be helpful?
No.
This
I
is
think you're
just the
fighting
wire.
an anatomic situation that's hard to fight.
You're trying to cross the
circ.
circ ostium.
Yeah,
Are
definitely.
you aiming to the proximal or distal struts?
Yeah, usually, as you mentioned, Xiaoling Chen is proximal, preferred by literature and the bench testing, some depending on fortune. Sometimes cross the proximal part is not easy.
Some people say central crossing would be better in terms of
Yeah,
cosmetically in OCT, but please keep in mind, avoid
Yes,
distal recrossing.
Sometimes you have to take what you can get, too.
This is choice PT wire. I'm gonna do shaping again.
Japanese guys monitor the crossing profile of side branch through such kind of Tosnet technique using OCT. Then they just cross and confirm the crossing profile. Then if it is not satisfactory, they just recross.
And
Post-23.
recross, and recross, and recross. Most of the time, they get where they want to go, but it's not always so easy. Plus you're also fighting here the underlying lesion morphology, which is not making it easy.
Oh, tester.
So, were your eyes closed as well?
Okay, I'm gonna do again. Okay. Sometimes we try to the proximal part as much as possible, but sometimes it's not easy. This is definitely, I think, a central
This
part.
is acceptable, I think.
Yeah.
Okay, Dr. Bach, we are going
Yes.
to move on the other
Okay.
room.
Okay, thank you. Okay, test.
Hello, Dr. Mintz and Dr. Kim. Can you hear us?
We
Yeah.
certainly can.
All right. Well, let me first start off by saying that it is truly a pleasure and honor to be at this iconic center here. If you think about where left main originated in Dr. Park's work, so just a real pleasure and honor. And for you to moderate Dr. Mintz, the world's authority in IVUS, and Dr. Kim, who's one of the preeminent researchers, clinicians, and trialists. So really pleasure and honor to be here. My colleague here is Dr. Lee, and he's going to present the case as well as introduce his team.
Okay, we have our fellow Dr. Bach here, and we have our nurse and techs. I'll just briefly introduce our case. This is a 76-year-old male patient. He felt some effort-related chest pain 1 month ago. So his ECG revealed that he had an LBBB, and his echo was normal. He didn't have any risk factors such as hypertension or diabetes, such a thing. So we already took the angio, and can we see the angio, please? So, right. Michael?
Yes, so let's start with the very first image. So this is a spider view, and there is at least an intermediate lesion in the ostium of the LAD. There is a subtotal lesion in the diagonal branch. So now we got to think in terms of addressing the osteo LAD, where do we land it? Do we try to be perfect, or we bring it back into the left main? So I think intravascular ultrasound would be very helpful. Next shot, please.
Okay. Just to remind that we already checked the FFR at the LAD, and
Yes,
it
it's
was 0.7.
0.7.
Yeah.
So in this view, I think you could clearly see that there is a subtotal lesion also in the LAD, that's why we take two contiguous views. So the areocaudal view again shows the severe osteostenosis. Let's go to the next shot.
Okay.
So this is an AP cranial view. There's a lot of overlap from the diagonal branch, but there is an osteodiagonal lesion, as well as a distal left main, which is moderate. This is an AP cranial view, which opens up the diagonal branch a little bit more. Next shot, please.
Next shot.
So, in summary, we have a gentleman who has a severe osteal diagonal branch. He's got a severe osteal LAD. There's some moderate disease in the left main. So I think there's many ways to address this lesion. So I'm going to start with the moderators and get some opinions from the people on the panel, how we should address these lesions.
All right, so I don't know, who wants to take a chance? Who wants to
And if you want
say-
to see the IBIS also, let us know.
Yeah, well, let's just take a look at, for the sake of time, let's look at the IVUS first, and then we
Okay,
can
great.
discuss.
IVUS, please.
Can you see the IBIS?
Yes, we can. So this is the
Fabulous.
LED pullback, correct?
Yes.
Right.
So we're just distal to the diag.
The size is 4.4.
It's big vessel.
Yeah. And there is I think this is a subtoe, right? It's a diagonal, sorry. It's a diagonal. And that you can see some disease coming up. The vessel size is about 4.5 or near 5. There's a concentric plaque here. The lumen is preserved. So you can see there is a starting
So now we're into the
huge
osteum of the
amount
LED.
of plaque. Right. It's the LAD. The circ coming here. A quite eccentric plaque, but opposite side of the circ. The
So
vessel
I-
size is quite big. Yeah.
So what's impressive is that even though the lesion is clearly osteal LED, the plaque extends proximal to involve at least the distal half to 3/4 of the left main. So even though it kind of looks angiographically like it's mostly osteal LED, the left main plaque burden is huge.
Right.
And
Correct.
that's
So-
what you see. I mean, in Medina 010 at the distal left main, 90% will involve the distal left main with large amounts of plaque.
And then one of the decisions that we have to make is where do we land the osteal LAD stent? Do we extend it back into the normal segment of the left main? So great. Let's see what the panel and the moderators have to say.
Did you image the circumflex or not?
We didn't. We didn't think that the circumflex was severe disease.
Okay. So now, okay, panelists, what would you do? Assuming we're going to do stent crossover, how would you strategize? How would you size this? What would you cover in terms of length and so on? Anybody?
I would, because it's a lot of plaque, I would prepare the lesion well, and then I'll probably stent near, close to the ostium of the left main, because the disease seems like extended near the left main, and I'll stent the LAD to the near normal segment, the 4O.
Tego?
Completely agree. We have to do to apply the stent crossover technique because distal left main is involved in the disease process, and even by eyeballing on angio, we see that the distal left main is somewhat smallest.
Chen Yudai, what would you do?
Yeah, depend on the angio and iris. It's the distal left main, the osteo LAD, but looks osteo of the circ is quite well. So my prejudice is stent crossover from the left main to the LAD. It's a prevention.
How about the diagonal branch? How would the panel address the diagonal branch?
I think I will leave the diagonal because it's some disease in the ostium, but it's vessel is not really very big.
Terashima, you want to say something? Yeah.
Actually, I agree with the crossover stenting, But in Japan, we can do the DCA. So in
Yeah.
such cases, we perform the DCA and the DCB, drug-eluting valve, in another choice in Japan. And also, I was finding very impressive to the proximal part. We can see the 2 layers. So
Yeah.
I think that some mural thrombus there. So very impressive I was finding in the proximal part.
What impresses me is this patient is mid to late 70s and there's almost no calcium.
Right. Right.
It's uncommon during live cases to see a paucity of calcium. I was hoping that there'd be some calcium so we could do some atherectomy today, but it's okay.
But, you know, maybe we can put the IVUS on full screen and we can show the multi-layer plaque in the left main.
Okay. Is it right here?
I mean, we can see in the upper left-hand
This part
corner, but
looks the
you can
two
sort of
layers.
see what Terashima was talking about, that it almost looks like either thrombus or a healed plaque rupture.
And so any consensus about how we should address the diag and then moving forward with the LAD distal left main?
Okay, so anybody who wants to do something to the diagonal?
I think just single crossover, but the point is where should be the proximal landing site and distal landing site? This landing site should be proximal to diagonal to avoid to compromise. And as we can see, the IVUS in the mid left main, there is some plaque rupture or erosion and thrombosis that may cause kind of unstable angina since a month ago. Thus, where is the optimal proximal landing zone of stent? Is it up until the left main ostium to prevent future event at the left main stalk? So what's your strategy, Dr. Lee?
Yes. So just going back to your first issue, yes, there's more plaque in the left main than I anticipated. So I think we have to bring the stent back near the ostium of the left main. And so, you know, the diagonal branch is not that small. And so to cross over, my concern would be losing the diagonal branch. So I decided to do a 2-stent approach of the LAD diag and extend the LAD stent into the left main. So basically we're going to do a DK crush. I think we could reference the DK crush 2 trial. 8 months angiographic follow-up. MACE was 10% and TVR was 6%. But I would argue that the left anterior descending is such a large vessel, it's going to do very well. And then we just had to make sure that the diagonal branch is optimized with intravascular imaging.
So why don't, I mean, so the devil's advocate, Dr. Kim suggested that you end the stent before the diagonal and just leave it alone. Why not?
If
Why
after
not?
you stand the left main and LAD, you do FFR, what's your, to the diagonal?
I mean,
my experience is that given the severity of the ostium of the diagonal branch, it's going to probably be ischemia producing. Except for that one diagonal branch, I don't see any other diagonal branches. So I think it's very important to preserve that. It's going down near the apex, and I thought it was at least a 2.5 millimeter diameter vessel, so I thought it was reasonable to go ahead and address it as opposed to a provisional approach. All right, shall we proceed forward? Okay, so we had some free time and we decided to proceed.
Okay.
All right, so what we did was first put a wire down the diagonal branch and we pre-dilated with a 2.5 by 15 millimeter balloon. Next. And the diagonal branch looks fine here. So next. So now we're going to do the first portion. The diagonal stent is a little bit too proximal. We decided to push it downstream further.
Okay.
Great. We're happy with that location. Next shot. We're going to confirm in the AKP cranial view. Looks acceptable. We're going to have to push the LAD balloon down a little bit further. Next. So we inflated the 2.5, 15 Zions in the diagonal branch. Okay. Next. And then we went high pressure with that same stent carcass just to make sure it would be easier to recross. Okay, so next. And then this is a 3-5-20 in the LAD where we crush the diagonal branch.
Right.
Okay, and then we also address the ostium of the LAD slightly into the left main. So far so good. I thought that a 2-5 was a pretty good size for the diagonal branch. And this is where we are right now. All right, so we had some extra time. We recrossed into the diagonal branch. So we're going to do a first kissing balloon. Okay. So we've already loaded our 2-5-15 balloon. Let's see if this crosses. So this is a 7-French guide, and that does help with this. So we crossed easily. I don't want to go too far distally. And I'm going to advance our LAD. It's a 2-5-15. We used our last 2-5-20 balloon. And these are compliant balloons, and we'll come back and do some NC afterwards. Okay, here we go. Great. So you have the diagonal branch.
Right.
Okay. What I want to do with the diagonal branch is go a little bit higher pressure. Okay, so let's go up there.
Okay.
Okay.
Diagonal.
2, 4, 6, 8, 10,
10,
12, 14,
14,
and down.
down.
Okay, great. I'm going to pull back the LAD just a bit. It just migrated. Okay. So let's go simultaneously. Okay.
All right.
2,
2,
4,
4,
6,
6,
8,
8,
and down.
down.
Great.
3.5, 2.5.
Great. So we're going to take out the diagonal branch next.
Okay.
You just finished the first kissing ballooning during
First kissing balloon.
double kissing DK crush technique.
Correct. So let's wipe that down. And can we open up that 4033 science, please? And we're going to make sure we don't forget to pull out the diagonal wire. Okay. So, did you flush? Flush that.
From the angel, it looks like the diagonal stands a bit too distal. The crush part, I don't see the two layers on the side of the wall.
Yeah, we could IVUS and we could, I thought I had enough osteal stent coverage into the LAD. Yeah. I don't want to protrude too much into the LAD because I really want to make it almost a mini crush for the DK. All right, so we're going to deliver this LAD.
At this point, in lengthwise, we can just treat the left main to mid LAD with just one long stent.
Correct.
But here, concerned about size discrepancy between left main to mid LAD. That's the reason why he just used 2 stents.
Well, I think he's going to have trouble, he may have trouble delivering that stent across the diagonal because of some of
I'm
the
going to pull
stents
back
sticking
that
into the...
diagonal wire. That might help us facilitate delivery. So we're going to pull the diagonal branch.
Yes.
Preserve
Wire
that.
braiding is very frequent phenomenon that hinder the smooth
Yeah.
advance of the second device.
There we go. Well, let's
But
do this.
still-
Let's get a 4015
Balloon.
NC.
All right.
Yeah. this
So
is free diagonal.
I think any concern that the diagonal stent does not protrude into the LAD
been
has
answered.
been answered.
One point zero.
So if this doesn't go, we have some other options. Buddy wire, buddy balloon. We could do a mother and child guide liner, catheter extender, etc. But I think we do some more adequate dilatation, it'll be fine.
The first kissing ballooning during decay crush may rearrange the side branch strut into the left main
LAD.
vessels. That may be a hurdle to the advancement of second stent.
So let's do this. Let's get a 3, 5, 12 compliant balloon.
Okay.
Yeah, let's take this out.
3.5, 12. 네.
3.5, 15.
Top,
Okay,
15 is fine also.
Dr. Lee, we just go to the other room because Dr. Park finished his procedure,
Okay.
and we are
Sure.
come back to you again soon.
Great.
Okay, can you hear me?
Yes, we can hear you, and we can see you.
We already finished the procedure, and after part using the 4.5 non-compliant balloon, and we recross. This is a 1.5 compliant balloon, as you shown before, and we pass the central part of the side branch ostium, and then we do 2 times, and then this is the final step using 3.5 non-compliant balloon suck, 3.5 non-compliant LAD, and this is the distal edge matching, and then high pressure. This is a stent booster, and then once again, here is we do high pressure dilation up to 25 ATM using 3.5 NC balloon, and then the sequential high pressure balloon LAD. This is a 3.5 high pressure NC balloon. We inflate up to 30 ATM. And then this is a final kissing, inflate 15, 15, 3.5, 3.5. And then once again, the kissing balloon dilation, 2 non-compliant balloon. And then this is immediate after. So we check this is a final angio, this is area coral view, additional, this is spiral view. You can see the distal main portion is okay. This is the epicranial view, it's okay. We already checked the final IBUS. Could you show us the suck first? Start. Okay, this is the suck and the middle part, and then you can see the interesting part of suck ostium coming. Okay, this is a prox suck. Okay, this is the POC zone, and the area was fully expanded. Also, we checked again from the prox LAD to left main. Prox LAD.
So that looks pretty good.
오케이. 좀 너무 뒤에서부터 보여줄 필요 없어. 키 포인트만 보여줘. 오케이, go. Start. Okay, this is the LED ostium. You can see the suck ostium. They're coming over there. Okay, 1 o'clock. You can see the, elliptical portion is fully expanded. Distal left main, the calcium nodal. Might be some change over there.
So,
Okay.
so if you go back until I tell you, I want to show you. No, put the IVUS back on, please.
Okay, I was back on. 조금 더 뒤로. Okay, start, go.
And I'll tell you when to stop.
Okay, stop.
So that's no, that's okay.
Okay.
Keep going.
자,
Keep
okay, keep
playing.
going 하다가
Keep
민트 쌤
playing.
스탑 한번
Keep
하시면
playing.
돼.
Keep playing. Keep playing. Keep playing. Keep. Stop.
Okay,
Stop.
Here.
Now go distally just a couple of. So what you see at 12 o'clock is calcium prolapsing through the struts of the stent. So tissue prolapse is not just lipid, thrombus, etc. It can be calcification. So these are parts of the calcified nodule, and that's what's causing the angiographic appearance. From 9 o'clock all the way to about 1 o'clock, you have bits of calcium protruding through.
Yes.
The lumen is big enough, but that's what's causing the appearance.
How do you differentiate it from the underexpanded strut? There is no strut.
There's no strut.
No. Can you see the IVUS image bigger?
I mean, you'll see as a pullback, you'll lose the strut and you see the calcium come through.
Okay, there is no
There's no strut. So you see basically, you see shadowing, if you will. So you can follow the stent struts proximal. Now you see the struts. Now they disappear, Now you see the calcium with the shadowing. Now you see part of the calcium. Now you see the struts again. And now, okay. We have
Okay,
some data
yeah,
to suggest that patients who have calcified lesions that are stented have a not as good a long-term outcome compared to a standard calcified lesion. We're still looking at it, but we have some data to suggest that.
Yeah. So, and the left main, that there is no inner position. We already did the 4.5 NC balloon up to 28 TM. I think this case is very interesting, and the severe calcium, sarcosteum, is acute angle. We have a lot of debatable portion. First, strong height selection, and also, as shown in our live demonstration, lesion preparation is the most important. If non-compliance doesn't work, we use the cutting balloon. If it doesn't work, finally we should decide to use low tabulation even in the distal left main bifurcation. This patient is luckily the cutting balloon work, and we did the balloon crush, and the final result, final albus is very nice. I think there are many good discussion point.
I mean, see, my only, just one possibility, I'm not that concerned. It's possible that at the site of the calcium prolapse, there have been a fractured strut or two, and I can't tell. Okay, you just can't tell.
What is the MSA in the left main?
Yeah, it looks like it's 4x4, so it's going to be somewhere in the 12 or more range.
Okay, thank you very much for your nice
Thank you.
presentation. We are
Thank
going
you.
back to the
Okay, thank
Michael
you.
Lee. Michael,
Yes, Professor Kim. So let's show them what we've done so far. So as you saw that we would require a little bit more preparation of the LAD. So after pre-dilatation with a 3.5/15 balloon, then we were able to deliver a 4.0 by 33 everolimus eluting stent. Next. Next. We flared it a little bit more. Next. Okay. Looks good. The RVD was about 5 in the left main, so we decided to go high pressure with the POTS with a 4.5 NC. Next. And then now we're going to retry to cross into the diagonal branch. I think I was able to get in. Let's get a little puff. Okay, let me see. Pull back here. Okay, puff.
Okay, does.
Okay, and then let's get that 2.5, brand new 2.5.
2.55 세워.
Okay, puff there.
Okay, just.
Okay, good. And then let's get a 3.5 by 15 Trek.
Okay.
Dr. Lee, where is your left main stent land approximately? Is it not at the ostium of left main, is it?
We came pretty close to the ostium, but not quite to the ostium. Yeah. So now we're going to go in with a 2.5, and if this goes in, then we'll do a final kiss, and then we'll maybe do IVUS off the error.
Can we see the spider angio after left main stenting?
Sure. Let me just take a picture before we cross. Oops. Actually, can you swing it over?
Okay, I just do it.
There we go.
Here.
Okay, ready for Cine? Inject. Okay. So I think this is actually a pretty good view for us to cross. Let's see. Okay. Got it?
Mm-hmm.
Pull back the diag bar just a hair. Okay, good. Okay, go to the cranial view. If this doesn't go, we will. Do you have a Takero balloon at Asan?
Don't think so.
Takero. All right. Let's see. Give it another try. All right, let's try to rewire this then if this doesn't. Actually, give me a 2.0 12 balloon. Let's try that.
2012?
Yeah. If not, we'll even go down with a 1.5. Great. Dr. Mintz, Dr. Kim, any other thoughts as we try to cross into the diagonal branch?
Well, I was just wondering, are you still happy you're dealing with the diagonal, or do you wish you would have stopped the LED stent beforehand?
No, I don't regret it at all. I think so far, angiographically, it looks very good. It's going to take some perseverance to get the diagonal branch open, but I think it's a pretty decent-sized vessel. In fact, I would say that with IVUS, it's going to be bigger than a 2.5. I was probably underestimating the diameter size, but I think it was a good idea to preemptively treat this.
What size balloon are you using now?
This is a 2.0.
Yeah.
Let's see if this crosses. There we go. Okay. Hold my guide.
Not yet.
Hold my guide.
Not
Yeah,
yet.
hold my guide.
I mean, you sort of have to,
me just-
I think what most people do is work with
There we go.
small
Okay,
balloons
let's
and
go high
upsize
pressure.
little by little.
Go high pressure, go about 30. Let me pull back my dial.
20, 24?
Yep, and down.
Down.
So I think this creates a channel and will allow us to deliver our 2.5. So I'm just going to do a, can you go neutral?
Yep.
And let me just give a profile there and
So what size
should
balloon
be
do you
fine.
really want to put in diagonal ultimately?
I'm going to go to 2.5, but the plan would be to IVUS again, and it goes fine. But I think it might end up being a 2.75 and even perhaps a 3.0, but I think IVUS would be very helpful. So we'll go back in with a 2.5 balloon, and then we'll do a final kiss.
Okay.
Yeah, I think in general, if the angle of separations between the LED and the diagonal is narrow, just like this, crossing the diagonal ostium is rather challenging. So we should not push too hard, otherwise we'll make indentation in the stents covering the diagonal, and it will create the restenosis later on down the road. So I think this is a good practice to use a smaller balloon, and then after that followed by the appropriately
Let's
sized
get
balloon.
the 3.5.
3.5. 15. Trick. Yeah.
Okay.
12:45? Lunch session.
The session's supposed to end at 12:30.
12:30,
The question is, can we go longer? Because I looked at the program.
So this is a used 3.5 15 balloon, and then we'll do a final kiss. Okay. Okay. Okay, great. So this is LAD.
Yeah, right.
Let's first go high pressure with a diagonal branch.
Okay.
So go to high pressure with diagonal
Right.
branch. 2, 4, 6, 8, 10,
16,
12,
20.
14, 20, and down.
Down.
Okay? And I like to say this is kind of just a little love tap. It's just a nice little kiss. Let's go to 2 simultaneously.
Okay.
2,
2,
4,
4,
6.
6,
Okay. And down.
1, 2, 3.
Because I don't want to go too high pressure in the LAD. So let's take the LAD out. Okay. And then let's take another angiogram, and then we'll optimize, and maybe we'll, if we have time, get the IVUS down to the diagonal branch. All right. Let me just take this out, and we'll take a picture. Okay. Okay, give me a small little test, please. Make sure my
Small
guide's
test.
good. Good. Ready?
Ready?
Inject.
Yeah.
Okay, let's go spider. Okay.
It actually looks quite nice.
I'm actually very honored you say that, Dr. Mintz. So we're going to IVUS now. Let's see what we have.
Okay.
So the LAD wire is below. So let's put the IVUS on that.
Okay. For IVUS, I gave some nitro.
Yeah, great. Here you go. And the circumflex looks preserved, which that was expected. Actually, you know what? Let's go down the diagonal branch. Sure. Because that's where the restenosis will occur. And if it's suboptimal, then we'll go back and touch it up.
This is diagonal.
diagonal.
Let me just double check this. Is diagonal. Yeah, that's diagonal. Dr. Kim, any other thoughts about this case?
What were the stents that you used? Zions?
I did use Zion stents.
Zion Sierra?
Correct.
Is there any preference for you to do such kind of complex two-stent technique?
I've just
No?
gotten very familiar with the everolimus-eluting stents. There's a plethora of data, especially with left main, the Excel trial, et cetera. So it's just been kind of my workhorse stent. So we're just distal. Good. Good. Let's start pulling back.
Yeah, pull back.
Got you. Good. So, Dr. Mintz, I'll give you the honors.
Yeah, I mean, I think it's well matched to distal reference. The only question is there any area of underexpansion?
I think there is. I mean, we were maybe a bit conservative.
Yeah.
We could always go back. I just didn't want to dissect it distally. Maybe afterwards we could calculate the RVD.
Yeah, I think, I mean, especially with smallish vessels, you can see that the diagonal stent actually extends into the left, into the proximal stent. I mean, it doesn't look crushed at all, quite frankly. I think that you have to actually do measurements, especially in small vessels, because the tolerances are not great. But
Actually, you can see here it's underexpanded.
Yeah, I think you've got work to do both in the main vessel stent and in the diagonal stent.
Yeah, I think this is a good example where IVUS is very helpful. But you know, you always have the opportunity to go back. This is a statement of, I wish I hadn't done that, which I think Barry Rutherford popularized. But yes, we will go ahead and go back and optimize the results.
Okay, so we've exceeded, we're at the end of our time. We'll let you continue to work in peace and you know, go ahead and optimize both stents and then re-image and so on and so forth. We want to thank you for a very interesting case. I want to thank my co-moderator, the panelists, the audience, as well as the live case operators.
Thank you.